as disrupting his social life. So, my question for you, what is this patient's primary problem or problems? What do you think? Heartburn, good. And if you had to quantify his heartburn, how would you describe it? Severe. All right, he's sweating. Anybody else? How would you quantify this gentleman's heartburn? I got Minion Box. Better than candy. Moderate. And how about the frequency? Frequency? Frequent. Okay, good. Excellent. Good. So this is moderate, frequent heartburn. What's the definition of frequent? More than how many days? 2 or more days per week. Yeah, that's an important, I would distinguish that. Because remember, we don't want to be recommending drugs like proton pump inhibitors for somebody who's really got infrequent symptoms. We know these drugs take a long time to work, right? So for self-care, just because the little purple pill used to once be a prescriptive product doesn't mean it's better. Any exclusions for self-treatment in this gentleman? Any reasons not to recommend a non-prescription medicine for him, for his symptoms? I jumped ahead to that one. What's his other problem besides the heartburn? He's flatulent, right? So he's got gas as well. Again, red flags, blood, severe symptoms, anything that you're concerned about, maybe masking a more serious underlying problem. It's okay to say no. Right, probably not. I mean, when I review this case, I don't see anything that's like glaring. He's a younger male. Again, he's had the symptoms for the past month. That's not in and of itself considered an exclusion for self-care. If he had these symptoms persisting longer than 3 months, then I would use some caution if going to recommend a non-prescriptive product. That's really outside the scope of our non-prescriptive remedies here. What are the options we could recommend for this guy? What are all the possible things that we could consider? Antacid. All right. What else could we recommend? Diet and lifestyle. Like what? What could we recommend from a diet and lifestyle modifying perspective? Good. If he told you that, he consumed that really, really hot stuff at Mamoon's right before this all happened, we would tell him lay off the hot stuff, right? What other types of foods did we talk about that can exacerbate these symptoms? Chocolate, okay. So if it was Thomas Sweet that he was overindulging in, we'd tell him to back off. Chocolate, caffeinated things, alcoholic beverages, right? Those are all different types of foods that can exacerbate. What about the timing with regards to when he's consuming foods? Good, at least 3 hours prior to bedtime. We encourage people not to eat. Don't eat and lie down, because then we don't have the force of gravity to keep everything where it's supposed to be. Good. Other options for him. I heard antacids from a drug perspective. What else? What other pharmacologic options could we recommend? Proton pump inhibitors. I like it. And how about for this gas? Is he a candidate for like lactate or alpha-D galactosidase, any of those enzymes we talked about? Down front, what do you think?
Simethicone?
What?
Simethicone?
Yeah, maybe some simethicone, sure. Probably not alpha-D galactosidase, probably not lactase, because he doesn't have a specific trigger that's causing those symptoms, right? But again, when we think about therapeutic alternatives, as a pharmacist, we need to be able to think about all of the options that are available to us. What's going to be the best for this gentleman? Optimal therapy, what do you think? Shout it out if you know it. Frequent heartburn. Frequent heartburn. PPI! Yes, good. So 2 or more days per week, you should be thinking about PPI. PPI use over-the-counter, non-prescription, is limited to how long without physician oversight? Say it with me. 2 weeks. I love it. How are we going to talk to this patient? So what are some important counseling points? We already mentioned some of the diet and the non-pharmacologic stuff. Who's got other points that they'd want to bring up with him? Other counseling, yeah.
Eating a smaller meal.
Good. Don't overindulge. So eating smaller meals. Again, overindulgence is an important cause of heartburn and dyspepsia symptoms. Any other thoughts? How about taking his medications? Any strategies there? Somebody who already didn't get a minion bug. I'm going to spread the wealth. When should he take his proton pump inhibitor?
You take it in the morning before a meal.
First thing in the morning before a meal. How come?
Because you want it to work.
Because you want it to work. Because your proton pumps are most active after a prolonged fast and before a meal. So first thing in the morning is really going to be the optimal time, because remember, these drugs knock out activated proton pumps. So that's probably the way for this gentleman to get the best bang for his buck. Is it going to work right away? Probably not. So if he was currently experiencing acute heartburn, maybe then we could recommend an H2 blocker and an antacid. But it's really going to take 2 to 3 days to see the full effect of this medication. But of course, this is going to be the best class of drugs for him. Good. Excellent. So that's everything I have. Any questions about heartburn, dyspepsia, or gas? We're good? All right. Now we get to talk a little bit about nausea, vomiting, constipation, and diarrhea. I love it. I have to tell you, the very first day I worked as a licensed pharmacist in the community pharmacy setting, the pharmacist in charge came in, showed me how to verify prescriptions, gave me a hug, and was like, good luck, go get them. Halfway through the day, there was a line of people at the register. It was like the first day when you're behind the wheel of the car after you got your driver's license, if you know what I mean. Like that same feeling was how I felt on the bench in the community setting. There was a line of people. People were kind of angry at my wait times. And in the midst of this chaos, a little older gentleman came to the counter with a question for the pharmacist, and he proceeded to tell me every bowel movement he had for the past month and a half. And when I tell you I was sweating under my white coat, I was like, what makes me qualified to listen to this story? I realized I had a license, and people will tell you all kinds of stuff because you're a healthcare professional, and they need help, and they need your advice. And he went from the whole gamut. He was constipated, and then he had diarrhea, and then he was back to constipation, and what did he want? What could I do to help? I recommended some fiber, and we talked a little bit about lifestyle, and then I went back to try and catch up with my prescription. So you have to be fluid. You have to be able to talk about these things conversationally without giggling. And also sort of realize there's so many different products that are out there for these conditions. You need to really be able to triage and make the best recommendation you can given a patient's symptomatology. So again, learning objectives, focus on your learning objectives as you prepare for the exam here. I hope you're able to identify the symptoms that are consistent with common GI conditions. Describe exclusion criteria for self-treatment. I know it's vomiting and diarrhea and constipation, and these are kind of vile subjects to talk about. The biggest concerns are, what do you think, the complications that could arise from these disorders? So what are you most concerned about when you're triaging a patient with diarrhea or with vomiting? Yeah, electrolyte disturbances and dehydration become a really important concern that we'll talk about throughout the lecture. Other learning objectives for each of the medications. Remember, I want you to know what the ingredients are in these various products. You should be able to describe how they work, so mechanistically, how these drugs work. You should be able to identify adverse effects, drug interactions. You should be able to identify important counseling points on how to use these products effectively. And if I give you a patient case, be able to select an appropriate intervention based on that patient's symptoms, or be able to decide if physician referral is warranted given those circumstances. So I'll talk a little bit about nausea and vomiting first. When I think about it, nausea and vomiting are really two of the most vital, awful complaints that you receive questions about as a healthcare professional at the pharmacy counter. And although these symptoms are generally benign, oftentimes they're self-limiting, meaning that if the patient did absolutely nothing, nausea and vomiting would resolve on their own. They can be associated with serious consequences, and other serious medical disorders as sort of depicted on this slide. When we think about non-prescription antiemetic uses, people will come to the counter, will ask you for drugs for motion sickness, for nausea and vomiting associated with pregnancy, and then often, maybe most often, non-prescription antiemetics are used for nausea and vomiting that are related to mild infectious diseases, whether they're bacterial, whether they're protozoal, viral. We don't have very accurate statistics to tell us how many Americans use over-the-counter or non-prescription products for nausea and vomiting. The best we can do in trying to figure out how prevalent a problem is this, how huge a market is this, we look at the sales data for some of the important brand names in these product categories. Pepto-Bismol, each year, that pink stuff accounts for $82 billion in pharmacy sales. Pepcid AC, $81 million bucks. And Dramamine, which is an antihistamine that's commonly used for alleviating the nausea and vomiting of motion sickness, over $20 million. So, the numbers let us know just how popular or just how widely used these agents are. Vomiting is a complex process, and I'm sure you talked about this in your hematology and oncology therapeutics. Really a complex process that involves the central nervous system as well as the gastrointestinal tract. We know vomiting is coordinated centrally in our brain by that chemoreceptor trigger zone, the CTZ, also affectionately known as the vomiting center. The vomiting center is really what receives sensory input from several different areas. That includes the chemoreceptor trigger zone, the vestibular apparatus within our inner ear, the cortex of our brain, and also from the gastrointestinal tract itself. The chemoreceptor trigger zone is found in the fourth ventricle of our brain. And we know that the neurons in this part of our brain are very sensitive to toxins and drugs. And there's just a very slight barrier here between the systemic circulation and the neurons in this area. So, any type of noxious particle then that's in our bloodstream is going to be readily delivered to this part of our brain, and it's going to have this unfavorable effect. Alcohol. Individuals who overindulge in alcohol, for example, a very common symptom of being too drunk, vomiting. Chemotherapeutic agents that are administered systemically, that enter the bloodstream. It explains why so many of our drugs for chemotherapy can evoke this same response. The vestibular apparatus, again, it's another part to this whole reflex. This is it's located in the bony labyrinth of the temporal lobe near our ear. The vestibular apparatus receives input via cholinergic pathways. Vestibular irritation is what's most likely attributed to the nausea and vomiting associated with motion sickness. If you can recognize that this is a cholinergic input, if you're blocking acetylcholine or if you're blocking cholinergic transmission with an antihistamine, again, the physiology sort of plays into the pathophysiology and understanding how we alleviate this type of nausea and vomiting. Our cortex, the cortex of our brain, is why when we see somebody else vomiting, some of us might join in with them. If we see something unpleasant, or if we smell something unpleasant, we blame our cortex for causing vomiting in that regard. And then finally, we've got the vagus nerve and our gastrointestinal tract. So we've got all kinds of input. If we eat something unpleasant, that can also stimulate sort of as a protective mechanism, the vomiting reflex, to protect us from toxins. Again, I think it's important and it's worth noting that most causes or most occurrences, most episodes of nausea and vomiting are self-limiting. These symptoms will resolve on their own in many instances if we did nothing. I think it's also worth pointing out that some causes that I've listed here may not in fact be self-limiting and may require intensive medical evaluation and treatment. So I sort of broke down my primary causes of nausea and vomiting based on the type of input. There's that visceral stimulation. Patients who have a gastrointestinal tract obstruction, very common, may experience nausea and vomiting because the contents can't move through their intestinal tract, so they come out the other end. Motility disorders. Patients who have gastroparesis. Patients who have various sort of esophageal problems, hiatal hernias, may experience vomiting as a condition of that hernia or of that disorder. Peritoneal irritation, also topical irritants to the gastrointestinal tract themselves. And then, of course, cardiac diseases, urologic diseases, kidney stones. Those patients, they come to the ER, and besides doing the kidney stone dance to try to get comfortable because kidney stones are so painful, very often renal colic or the pain associated with kidney stones can cause patients to vomit. Overeating, overindulgence. Of course, central nervous system disorders, disorders of the inner ear, the vestibular apparatus, individuals with increased intracranial pressure, so trauma victims, closed head trauma, concussions, infections like meningitis, and then of course whenever you've got irritation to the chemoreceptor trigger zone. We know medications can do that, like we mentioned, and then other systemic disorders where that could occur. This slide just depicts some of the major mechanisms that are involved with eliciting the vomiting response. We talked a little bit about these things, so I don't really want to belabor it, but you should realize that depending on the mechanism that's involved, there are some major neurotransmitters and receptors that are involved in initiating the vomiting response. The neurotransmitters really come into play when we start to discuss the medications in a little bit. So we've got psychogenic vomiting that comes from the cortex or the limbic system. We talked a little bit about motion and space sickness from vestibular and visual elements. Dopamine, it's dopamine's activity at the D2 receptors. It's histamine, interacting at the histamine type 1 receptors, the muscarinic, the M1 receptors, and then also a little bit of serotonin. And substance P are sort of our major neurotransmitters that are involved with some of these processes. I'll talk about motion sickness first. When we think about the nausea and vomiting associated with motion sickness, we have to remember that we get three sources of sensory input. Our bodies, so we know where we're at in space, we have three pieces of information that are constantly being relayed to us. We get visual cues, right? So our eyes give us the visual input that lets us know where we're existing in our environment. We've got sensory fibers in our muscles, and our tendons, and our internal tissues that are responsible for proprioception. And then, of course, we've got our vestibular apparatus. We've got our inner ear, where we've got those cholinergic receptors that help let us know what's happening. Motion sickness happens when the visual cues don't match the sensory input from our muscles or from the vestibular systems. And this often leads to nausea and vomiting. The body moving, for example, when the visual field remains constant. Anybody ever feel sick while watching a 3D movie or an IMAX movie? Right? Like totally. Like for me, sometimes it's like disorienting. I'm like, I need to shut my eyes. One of those immersive 4D rides, for example, when we see vivid images that are projected on a screen, they send signals to our body They tell the body that we're in motion, but of course the inner ear, the part of the, where the fluid is, that's used to help us sense motion and balance, the inner ear doesn't sense that change. It's just because of the visual inputs that are being thrown at us from the scene, the screen rather. So the eyes tell us we're moving, but the ear doesn't, and this is a recipe for nausea and vomiting for some people. On the flip side, when you're reading in a car, for example, anybody here like to read in the car? I love to read in the car, but it gives me a headache and then it sort of makes me feel pukey, which is classic motion sickness. Your eyes and your visual fields are focused on your book if you're doing that, and you don't necessarily sense that your body's moving. Of course, the fluid that's in your ear senses that the car is in motion, and the difference in the sensory input, what you're getting from your eyes versus what your ears are telling you is your trajectory in space, result in dizziness and sort of this unpleasant sensation of motion sickness. Motion sickness is often very benign at first. You feel kind of drowsy or tired, and if you don't realize what's happening or you don't remove yourself from that situation, you're going to be reaching for the barf bag, because very often that sort of prodrome, that warm feeling, turns into nausea and vomiting, again, if you don't remove yourself from the situation. Nausea. So some of the signs and symptoms we're talking about here. Nausea is a vague, unpleasant sensation, epigastric and abdominal distress, right? Regurgitation is actually when gastric contents come back into the pharynx, usually associated with sort of an unpleasant or a sour taste in the mouth. Retching, dry heaving. And then, of course, vomiting is a physical expulsion of stomach or esophageal or oropharyngeal contents. The acute complications of experiencing vomiting, as we mentioned, dehydration and electrolyte abnormalities are probably the first two that should come to mind. But we also have to worry about aspiration. And then if this is chronic, malnutrition, malnourishment plays a role as well. Again, dehydration is one of the major concerns that are associated with vomiting. And some clues that a patient might be suffering from dehydration include a dry mouth or dry mucous membranes, reduced skin turgor. So, our skin usually snaps back into place if we pinch it under the skin on our wrists or stuff like that. If this were to tent, if it were to stay up after I had pinched it, that's an example of decreased skin turgor. Excessive feelings of thirst, dizzy, lightheaded, and then of course fainting or dropping one's blood pressure, all examples. Treatment. So who do we recommend non-prescription antiemetics to? Really, our non-prescription antiemetics are okay to use for occasional symptomatic relief. Again, nausea and vomiting tend to go away on their own if we did nothing, but our non-prescription antiemetics can help patients feel better and help alleviate the symptoms while the patient is acutely ill. Again, the other important aspect to self-care when we think about nausea or vomiting, especially vomiting or even diarrhea, we have to think about dehydration, and that's the other piece of the non-prescription medicines we'll talk about. In terms of treatment, we want to be able to identify and correct the underlying cause. If you can't figure out what caused the nausea and vomiting, you're not going to be able to effectively recommend treatment. So identifying a cause is important. Recommending appropriate non-prescriptive therapy. And again, our non-prescription drugs, they're not going to necessarily treat that underlying cause, but of course they're going to provide some symptomatic supportive care, relief until, again, the patient feels better. I summarized some of the general treatment approaches for adults, and we'll dissect each of these in a little bit more detail. For pregnancy, the non-prescriptive, non-pharmacologic approach is really rest and non-pharmacologic measures, eating small meals, medical referral, making sure that a pregnant woman is not self-treating and she's really selecting over-the-counter remedies with her OBGYN's advice is paramount there. For motion sickness, we're going to talk about the over-the-counter antihistamines. Overeating, lots of overlap with heartburn and dyspepsia like we just talked about. We've already mentioned the antacids and the H2 blockers. We already talked about Pepto. I'll also make mention of the phosphorylated carbohydrate solution. Food poisoning is all about rehydration. And then again, medication-related nausea and vomiting, it depends. It depends on the medication. We may be able to point patients into the direction that a medication could be responsible for their symptoms. Who shouldn't recommend, or who shouldn't we be recommending self-treatment for? If individuals believe they're experiencing food poisoning, the way it works with food poisoning, after you've experienced that diarrhea or that vomiting, after the offending agent is gone from your intestinal tract, your symptoms should at least theoretically resolve or get better. If an individual is describing symptoms that are lasting longer than 12 hours, they may need medical referral. Perhaps they need an antibiotic or something to really address the underlying cause. Perhaps it's not food poisoning if the symptoms are lasting so long. Anybody with severe symptoms, again, anyone who is doubled over and they can't come into the pharmacy, they're calling you and saying, listen, I have really severe cramping or, vomiting that's associated with these symptoms. It's probably time to be seen. Fever or diarrhea, so more systemic symptoms or other symptoms accompanying the nausea and vomiting beyond just nausea and vomiting. Blood is always a red flag, right? So if I tell you on the exam somebody's got blood in their vomit, don't pass go, don't collect $200, recommend they go to urgent care and be checked out for that. Dark urine or jaundice, what am I concerned about? Dark urine, jaundice, liver injury, right? Some type of underlying cirrhosis or liver dysfunction. Pregnancy or nursing, again, many of the over-the-counter antiemetics are not approved for use by pregnant women. Pregnant women, we really want to be pulling in their OBGYN into this discussion. Head injury, why do you think nausea and vomiting accompanying a head injury is not recommended for self-care? Concussion, I heard it, right? Concussion usually requires supportive care, but if a head injury just did take place, we want to make sure that that person's got appropriate medical evaluation and imaging if necessary. Severe headache, stiff neck, or photophobia. What's that sound like? Meningitis, totally. So that nausea and vomiting we're not going to address. Nausea that's caused by cancer or adverse drug effects. If the adverse drug effect is such that the drug is going to have to be discontinued and changed, again, medical referral. Psychogenic causes, again, medical referral. And then with chronic diseases, really the only reason that these chronic diseases show up on my exclusions, individuals who've got glaucoma or COPD or asthma BPH, they're going to be excluded from use of the antihistamines that are indicated for nausea and vomiting associated with motion sickness. And then I'll talk a little bit about children. So again, with kids, with motion sickness, we want to try and avoid precipitating factors if possible. So if you know your kid is likely to vomit, don't stick them on It's a Small World in Disney or something like that. Over-the-counter antihistamines. We'll see that not all of the over-the-counter antihistamines have the same age indication. So some of the products are really dependent on the child's age with what you might want to recommend. If a child has gastroenteritis and they don't have symptoms of dehydration, we may want to recommend oral rehydration solutions. And then, restarting feeding with light solids or formula. Antiemetics are not, in fact, indicated for gastroenteritis. Again, the concept is that's our body's way of getting rid of that toxin. And then for episodic or situational nausea and vomiting, we'll talk a little bit about phosphorylated carbohydrate solutions. For children shouldn't receive treatment with over-the-counter antiemetics if they've got signs of severe dehydration, or if their caregiver is really going to be unable or unwilling to manage their symptoms at home. Again, in children, if they have a stiff neck, if they're younger than 6 months of age or they're less than 8 kilograms, infants that fall into this age group are very susceptible to dehydration. So you want to educate those parents or those caregivers that really medical evaluation may be warranted. If the kid doesn't want to drink, I'll tell you that these oral rehydration solutions, they're loaded with electrolytes. Guess what they taste like? Because they're loaded with sodium and some of these other things. They taste salty. So, when we taste test these products in pharmacy school, I'm like, oh, well, it's a little salty. That's not so palatable, but whatever. Man, trying to squish it into a 3-year-old and be like, take this, you have severe diarrhea. It's hard to get kids to be compliant with these things. That's why they come in ice pops and, we call it affectionately puke juice in our house. You have to try to trick kids sometimes. It's hard to get them to take these things by now. If the kid's not willing to do it, they may need IV fluids. Lack of urination. That's a good indicator that that child is not taking in enough fluid. If they're lethargic or sleepy, if they're vomiting each time they're being fed. So these are all cues that it's time to call the pediatrician. Non-pharmacologic interventions for self-care for nausea and vomiting are sort of the common sense things I think we all do when we experience mild self-limiting episodes of nausea and vomiting. Again, the appropriate non-pharmacologic intervention sort of depends on the type and cause of the patient's symptoms. I've listed these general treatment options here, but you can think about this. If somebody has some type of gastroenteritis and they've got nausea and vomiting because of something they ate, maybe a Brower Commons, the natural thing I think most of us are going to do is to nibble on dry toast or crackers, maybe sip some ginger ale until we start to feel better. Right? So sort of those common sense things, it may be appropriate to recommend those types of things to the patients that you'll counsel at the pharmacy as well. Drinking sips of liquid between meals. Carbonated beverages or fruit juices may be best in this regard. My kids love it because when they have, some viral GI bug thing, they're like, oh, Mom, I have to get the Pepsi Cola to drink. Darn it, you're too smart for your own good, 6-year-old. So they know, even as a 6-year-old, that Pepsi Cola, that carbonated beverage, and what makes those beverages, what gives them their color? Pepsi or Coke, whatever your preference. Phosphoric acid, and there's sugar in there. So that's actually a phosphorylated carbohydrate beverage. Right? So absolutely, sipping things like Coke, Coca-Cola, Pepsi-Cola totally makes sense. Ginger ale, ginger is sort of being a natural sort of antiemetic. Eating 4 or 5 small meals per day, not overdoing it when somebody's recovering from some type of acute episode of nausea and vomiting. And of course, avoiding trigger foods that aren't very gentle on the gastrointestinal tract, like greasy, spicy, or acidic things. For nausea and vomiting of motion sickness, there are non-drug approaches that are available in the community pharmacy. So there are 2 products. There's an acupressure wristband. This is known as C-bands or travel aids. They're actually indicated not only for motion sickness, but for nausea of pregnancy and nausea even associated with chemotherapy or anesthesia. The way it works, you buy the little packet of wristbands, and it's literally, it comes in a pack of 2 wristbands. There's a little hard plastic kind of bump, it's almost like a marble, that rests on the inside of your wrists. It's worn bilaterally. And the thought is that these acupressure wristbands are putting pressure on a pressure point that's likely to be associated with nausea and vomiting. And it may in fact relieve symptoms of nausea and vomiting. Again, it's non-pharmacologic. There's no contraindications to use. It can even be used in pregnancy because it's not taken systemically. There's also this AccuStim wristband. These are harder to come by. You can find them online. The relief band is a battery-powered device that is actually FDA approved for treating nausea and vomiting related to motion sickness, and also mild to moderate nausea and vomiting with pregnancy. This type of device, you wear it on one wrist, unlike the acupressure bands, which are worn bilateral. You wear it on one wrist, and it stimulates that same acupuncture or acupressure point with electricity. So it's got like a little battery that, again, is thought to cause relief. Non-pharmacologic, non-drug approaches, really side effect free. The only thing is the patient might be out a few bucks if it doesn't work for them. Drug therapy. So again, the drugs really depend on the type of nausea and vomiting. We'll talk about the antihistamines for motion sickness, and then we'll review some of those products that can be used for food-related nausea and vomiting. Remember, as we mentioned, with regards to how the antihistamines work for nausea and vomiting and motion sickness, histamine levels normally increase in our brains in response to certain motions. So by giving an antihistamine, what we're actually trying to accomplish with our drugs is to reduce the stimulation, that cholinergic innervation in the labyrinth of our brain, in the labyrinth of our inner ear. So these drugs can be used to prevent and control motion sickness. They are not indicated for the nausea and vomiting that's associated with pregnancy. Remember, pregnancy warrants medical referral and evaluation in most instances. When I think about the antihistamines, just like with allergic rhinitis management, drowsiness is the major adverse effect, and it can occur even at therapeutic dosages. Again, you want to caution your patients not to combine antihistamines and alcohol. So if they happen to be going on a cruise, for example, you might want to use some guidance there. Also, if they'll be driving the vehicle, engaging in tasks that require a high degree of mental dexterity, it's the same concept with antihistamines that are used for seasonal allergic rhinitis. There's also some issue with anticholinergic effects. There's actually a prescriptive antihistamine. You guys know the patch? What's the patch called? The scopolamine patch? Right? It's an antihistamine. You stick it on the back of your ear. You wear it for like 3 days or something at a time. Anecdotally, I've heard reports people, are going on the cruise of their lifetime and they can't leave their cabin because they see snakes on the wall. So hallucinations because of too much anticholinergic activity can also happen. Things that you just may want to alert your patients to so they're not like, what's happening? Again, caution here. Antihistamines, of course, in individuals who have glaucoma, who have COPD or asthma, or who have obstructive genitourinary disease, remember your antihistamines can exacerbate those conditions. So in those patients, antihistamines are not indicated. Drug interactions, we mentioned caution when combining antihistamines with alcohol and other sedatives. And remember that other anticholinergics can have additive effects if they're used in conjunction with the antihistamines. And again, just a comparison, these are the various non-prescription antihistamines. Benadryl or diphenhydramine is not frequently sought out for this indication, but Dramamine or Merenazine or Bonine are the formulations that are readily available and often sought out by patients looking to alleviate or prevent motion sickness from happening. I've included the adult dosing recommendations. For the pediatric indications, I'd just like you to be aware that the doses vary for children. And certain products are, in fact, not even recommended for use in children as well. So just realize that, again, children sort of have some different indications and dosages that are recommended. Nausea and vomiting associated with food and beverage. So we've talked about really all of the agents that are listed here, maybe with the exception of the phosphorylated carbohydrate stuff. If you recall, the antacids, the H2 blockers, the PPIs, omeprazole, and the Bismuth products can all be used to alleviate symptoms of overindulgence, including heartburn, indigestion, and nausea and vomiting. The product I do want to spend just a few moments on is this phosphorylated carbohydrate solution. And you already told me that the Pepsi and the Coca-Cola that's at your seat, that is a perfect example of a phosphorylated carbohydrate. We also have a non-pharmacologic option. So this is a product that's on the shelves in the pharmacy in the GI disorders section called Emitrol. Emitrol is a mixture of fructose, glucose, and phosphoric acid. And essentially the osmotic effect of this drug inhibits gastric emptying and it slows GI motility. Emitrol is indicated for emesis associated with intestinal flu, food or emotional upset. The patient populations where you have to worry a little bit about recommending these carbohydrate-based solutions, people who have diabetes, just because whether it's Emitrol or whether it's full sugary Coca-Cola, we've got a concern where we could exacerbate blood glucose control, and that may not be optimal given that patient's diet and given their approach to managing their condition. The other patient population to use caution, hereditary fructose intolerance, again because the Emitrol product contains fructose as one of the ingredients. In the olden days, you used to be able to find concentrated Coke syrup. So essentially the syrup that's used to make Coca-Cola was sold at the pharmacies. In some of the smaller independent pharmacies, you may still find Coke syrup on the shelf. Coke syrup, again, Coca-Cola does the same thing as what you're trying to achieve with the phosphorylated carbohydrate solution. We also have the oral rehydration solutions. And again, Pedialyte comes in a number of different dosage forms. Now, my image is a little bit blurry on there. There are singles, so Pedialyte that comes in like a dry powder that you mix up in your water bottle. A favorite in my house are the Pedialyte Ice Pops. Just what you want when you have a fever and you're puking everywhere. At least I can get you to take it. At least I can get you to take it. Tastes a little salty, but whatever. Really, when we think about these rehydration solutions, well, you guys tell me, what are they being marketed now? How are they being marketed to your generation or your demographic? The hangover helper, I heard it, good. Somebody gets out, yes. So these are absolutely indicated. It totally makes sense as a hangover helper, right? Because you're giving back electrolytes and helping restore volume. Nausea, vomiting, and diarrhea in adults and children we know is dangerous. It's got some potentially dangerous consequences. Recent guidelines that came out in the pediatric literature recommended supportive care for gastroenteritis in kids, and that included dietary modification as well as fluid replacement. Oral rehydration solutions, when we think about it, are really the primary treatment for minimal or mild or moderate dehydration. The CDC actually recommends that parents keep these solutions on hand for when mild to moderate episodes, viral things come into play, and in case a child is affected by diarrhea or nausea, vomiting because of a gastrointestinal illness. Now, what about Gatorade? What about Powerade? What about all those other sports beverages that are electrolyte enhanced? So what's the downside to using those preparations if you've got nausea or vomiting or even diarrhea? Does anybody know? So there's sugar in them. Right? These don't contain sugar, so they also don't taste as good. They don't contain sugar, kind of a salty taste to them. Sports drinks, or gelatin water, or fruit juices, they're actually discouraged, especially in pediatrics, because the carbohydrate load in these products, they're actually hypertonic. And when you drink them, they pull water into the gastrointestinal tract because of their osmolarity. And that can actually exacerbate diarrhea if it's present. So again, I'm a big proponent. I love to recommend oral rehydration solutions because the electrolytes are really giving back to the patient what they're losing in their vomitus or in their diarrhea. Again, dehydration happens when we lose extracellular water. We need sodium in order to be able to take up water efficiently into our cells. If we're drinking this, what is this? Does anybody know what this is? In the hospital, we would call this free water, right? This is free water. There's no electrolytes in here. Too much free water. What can too much free water exacerbate or cause? Hyponatremia, exactly. So, it sort of really intrinsically makes sense to recommend something that's giving back electrolytes in addition to water in someone who's experiencing extracellular losses of these items. Again, the intent with rehydration solutions is to provide fluid replacement that mimics the fluid that's being lost in the extracellular losses. The dose depends on how severe the dehydration is. Hopefully toward the end of the semester, we'll have a product display where you get to play with some of these things. You'll notice on the labeling, the dose of the solution is really measured based on the weight loss. Maybe I'll buy some. I'll bring them to class on Wednesday to taste in our interactive session. All right, I'll note to self. Special patient populations, pregnancy and lactation. Important to remember, nausea and vomiting could be a first sign of pregnancy. We'll talk about in our pregnancy prevention lecture, 50% of pregnancies in our country are in fact unintended. Surprise! So it's important if a woman could be of childbearing age to evaluate could they in fact be pregnant. Again, using over-the-counter antiemetics is only recommended under physician supervision. It's okay to recommend a product if a woman said, my OB/GYN said to go pick. Well, then I can help you make a selection there. For children, antacids and HG blockers are okay if their pediatrician is recommending those products be used. Again, we've got pediatric Pepto that contains calcium carbonate, so patients can select those things on their own. Children, remember, don't usually develop symptoms like heartburn, as we mentioned, but nausea and vomiting is not uncommon. Oral rehydration solutions. And then again, if it's nausea and vomiting related to motion sickness, antihistamines might be indicated, and avoidance of bismuth because of that risk of rise syndrome. In our older adults, remember that this is also a population that are prone to dehydration. So we need to use some caution there. And also keep in mind that antihistamines, when used for motion sickness, maybe need to do that judiciously because that can increase risk of our older adults falling. So just some points to remember with nausea and vomiting. Correct the underlying cause if possible. Remember, non-prescription antiemetics are useful for preventing and controlling occasional or self-limiting symptoms. For motion sickness, really, antihistamines are the drug category we should be recommending. And then again, anybody who's more complicated than just mild to moderate self-limiting nausea or vomiting really requires medical evaluation and additional medical workup. I want to talk about constipation. Not a sexy topic, but important to recognize that 2 to 28% of adults in the United States experience constipation each year. 2.5 million physicians visits and over 100,000 referrals to gastroenterologists happen each year because of constipation. Constipation is heterogeneous. It happens across the lifespan, although it is more common as we grow older, and the elderly in particular are more susceptible to constipation. It's more common in women than men, and it's also a very common complaint associated with pregnancy. When I look at the different causes of constipation, the Rome 4 guidelines have very specific, nuanced criteria for the different types of constipation. For our purposes, when we look at causes of constipation, we've got primary or idiopathic constipation, and then we've sort of got secondary constipation that happens because of something else. When you look at the different types of primary constipation, there's normal transit, which is the most common. That means that the mouth to anus transit time, nothing has slowed down along this process, but the patient is still having difficulty evacuating or they're passing hard stools. Slower transit, obviously this is constipation that arises because the transit time, mouth to anus, is a little bit slower. And again, the movement of gastrointestinal contents isn't happening at sort of the normal pace. And then we've also got outlet obstruction. And those are those patients who've got an inability to evacuate stool from their colon. Usually associated with muscle issues, pelvic floor dysfunction in women, issues with the anal sphincter. Our traditional laxatives really don't address outlet obstruction type constipation. Constipation, interestingly, most patients who've got normal transit constipation, they actually fulfill the diagnostic criteria for like irritable bowel syndrome or constipation predominant irritable bowel syndrome. That means that 25% of the stools they're passing, they're having a hard time passing those stools or difficulty evacuating those stools. Secondary, again, you know it's a safe bet on your rotations. If your preceptor asks you to name a drug-related side effect, constipation is up there because there's a laundry list of drugs that are notorious for causing constipation as a symptom. Our calcium or our aluminum-containing antacids, iron supplements, various diuretics, inadequate dietary fiber, inactivity, and then also underlying diseases that may be present. So a whole lot of things to think about in evaluating a patient who complains of constipation. With regards to signs and symptoms, it's important to remember that the frequency of bowel movements is very variable. Does anybody know what the definition of normal bowel movement is? Anywhere from 3 times a day to 3 times a week is normal. So that's huge as far as variability goes. We can't just have patients tell us the number of stools they're having per day and be able to effectively determine whether or not they're constipated. Constipation and not being regular depends on regularity. What's regular for the patient is normal. Again, regularity or feeling regular is just what's typical for the patient when they are not feeling constipated. We can't define constipation by the number of bowel movements per week, but we can look for symptoms. So if the decrease in the frequency of bowel movements is also associated with anorexia or a headache or lower back pain or abdominal distension, that tells us that this is now a condition that's really bothersome for the patient. Abdominal discomfort. Again, it's not defined by the number of bowel movements, so we can't use bowel movements as a marker. We have to use these other clues. Again, when treating constipation, we have to take a look at dietary habits, at a patient's lifestyle. We know inactivity can exacerbate or cause constipation. Medication history. With diet, we see this a lot of times in the inpatient setting. The team's like, well, this patient is constipated. Okay, well, it could be the pain meds they're on, but have we fed them? Are they eating? The number one stimulus to peristalsis is food intake, is food. So if somebody's not eating, they're going to be constipated. There's not going to be anything coming out the other end because there's nothing going in. Medications. Right? We talked about the fact that numerous medications and checking and evaluating the prescriptive profile can be very helpful, not only in identifying potential drug interactions with non-prescriptive options you'd like to recommend, but also to identify any medication-related causes of constipation that might be present. Your Quest Scholar approach, how old is the individual, how long have they been experiencing these symptoms, what have they tried and has made it better, what's made it worse, any history of laxative use. Could they be pregnant? Always a good question. Treatment goals, we want to relieve constipation and help reestablish normal bowel habits. Also to help patients establish good habits overall, exercise, dietary interventions, adding fiber to their diet in order to prevent recurrences of constipation. Promoting safe and effective use of laxative products and avoiding laxative overuse. When we talk about non-prescriptive medicines that can be abused, laxatives appears up there on those lists of products. And when we look at laxative abuse, we actually see sort of a bimodal distribution. We see adolescents, individuals with eating disorders, anorexia, bulimia at one end of the spectrum. The other age group who abuse laxatives are older adults. I guess when you retire, one of the things you have to look forward to every day is being regular in a bowel movement. So a lot of times in our older adults, with laxative abuse, physical dependence on laxatives to have a bowel movement, when there's absolutely no medical indication to use these products. So, no pun intended, but I'll call this the bottom-up approach to treating constipation. When I think about a general treatment approach, if somebody is constipated, well, our first step is going to be to recommend dietary and lifestyle modifications, and then maybe adding bulk-forming laxatives. Bulk-forming laxatives like fiber, F-I-B-E-R, these are the most physiologic interventions for promoting laxation. So keep hydrated, get moving, consider adding fiber. If that doesn't work, we can consider saline or hyperosmotic laxatives. If those don't work, we've got stimulants, and then all along the way, we've got stool softeners. That's really for mild constipation. If somebody comes to the pharmacy counter and they haven't had a bowel movement in 3 or 4 days, you're not going to tell them to drink water and take fiber. At that stage, it may be more appropriate to sort of ratchet up and start with a hyperosmotic or even a saline laxative or stimulant. When patients are picking up bowel preps, they're going for a colonoscopy or a procedure of the colon, stimulant might be the way to go. So again, this is sort of the bottom-up approach. We've got other interventions based on, if it's opioid-induced constipation or other types of constipation where we may be more aggressive, so just realize that. Exclusions, anybody who's got severe abdominal pain, distension, or cramping associated with their constipation. I'm worried about obstruction, right? So a clue that a patient could actually have obstruction might be the fact that they've got pain. That's really severe. Systemic symptoms, fever, nausea, vomiting, accompanying that constipation, or unexplained flatulence. If they already tell you that they're using a laxative on a daily basis, bloody stool, dark tarry stools, symptoms persisting longer than 2 weeks, or a history of inflammatory bowel disease, a history of ulcerative colitis or Crohn's. Non-drugs. So the non-drug approach is here, gradually increasing dietary fiber intake. And that means starting with 2 servings per day of foods and fruits like you guys mentioned, and increasing those servings over every 7 to 10 day period with a target of like 30 grams of fiber per day. Drinking plenty of non-caffeinated beverages, W-A-T-E-R. Not tea, not coffee, water, because that can sort of naturally serve to hydrate our intestinal contents and prevent constipation. And then also increasing aerobic exercise, walking, jogging, swimming, all good things for stimulating GI motility. With our drug options, we've got a whole bunch of laxatives in our armamentarium. So we've got a whole slew of treatment options we can recommend. We'll talk about bulk forming, our hyperosmotics, and our stimulants and stool softeners along the way. Bulk forming laxatives generally are our first choice for the treatment of constipation. The exception would be in patients who are obstructed or in patients who have opioid-induced constipation. Bulk forming fiber-based laxatives are in fact contraindicated for use. The reason for most people with sort of idiopathic constipation, why bulk forming agents are sort of the number one go-to, as I mentioned, they most closely approximate our normal physiologic mechanisms in promoting evacuation of our colon contents. They help us retain water in our colon, that increases the intestinal bulk, that stretches our colon, and stimulates peristalsis, along with stool water content accumulation. All right, so these guys, they kind of work like a sponge in our colon and in our intestines all along the way to absorb water, and again, mechanically to stimulate peristalsis. They don't work right away. They can take 12 to 24 hours or longer in order for a patient to have a bowel movement. So again, this is not an acute fix to somebody who's not had a bowel movement in several days. This is an intervention to promote laxation and to prevent constipation, potentially for future episodes. We talked about the fact that there are several different types of fiber supplements that are available. We've got, again, these are functional sources of fiber, natural or semi-synthetic polysaccharides that exist. Adverse effects associated with fiber: cramping, bloating, and flatulence, just like beans or prunes or other things that you might consider increasing in your diet that are rich in fiber. And again, patients who shouldn't be receiving these products are those who are either fluid restricted. Each time you take a fiber supplement, it should be taken with a full glass of water in order to prevent obstruction. People have choked on fiber supplements because if they expand in your throat before they're down all the way, again, we can kind of get into issues with that. Esophageal or intestinal obstruction can occur. So anybody who's fluid restricted, who's got partial intestinal obstruction or trouble swallowing, this may not be the best option for them. So just some examples. We're going to sample some Metamucil in class on Wednesday. I'll also bring some alternative fiber cookies and alternative dosage forms for us to taste as well, if you want to, if you choose to. We've got our hyperosmotics. We've got saline laxatives, we've got lactulose, and we've got polymer type laxatives that fall into these categories. Again, I just for completeness sake, I'd be remiss if I didn't at least mention lactulose. We use lactulose a lot in the inpatient setting. It is an RX-only product, but many of these hyperosmotics are available over the counter. Saline laxatives, although their name is saline and you're thinking sodium, these are really solutions that contain non-absorbable ions that work by creating an osmotic effect that really draws fluid into the intestines. And it's the increase in the intraluminal pressure that mechanically stimulates peristalsis occurring. Examples, saline laxatives usually contain things like magnesium salts. Again, contraindications, well, some of that magnesium salt can be absorbed. So if you've got renal failure, you're not going to be able to eliminate magnesium efficiently. If you've got heart block, that could precipitate an arrhythmia. If you've got an ileus, well, that's bad because that magnesium, again, is going to be absorbed and have nowhere to go, but into your intravascular circulation. Again, some of these do contain sodium. So patients who are fluid restricted with heart failure or cirrhosis, that may not be optimal. These are very potent laxatives. So whereas the bulk forming agents tend to be fairly well tolerated, these guys are notorious for causing cramping of the intestinal tract, also excessive diuresis, dehydration, and electrolyte abnormalities. Because they contain cations, you may need to separate these by 2 hours or more when taken with other cations or antibiotics. And again, readily available over the counter. Mag citrate, magnesium hydroxide, good old milk of magnesia. And then we've historically had some sodium phosphate-based saline laxatives available without a prescription. Patients will ask you, well, that mag citrate, it comes in like a citrus flavor or a cherry flavor. What do you recommend? What do you think pharmacists to be? What's the preference? So the citrus is always the better option. Citrus masks salt better than cherry and fruity flavors and stuff like that. So you always recommend the citrus if they ask. There were some issues. Several years ago, the sodium phosphate products, they really recommended that these products be sort of removed from the market, reformulated, because people were developing acute kidney injury because of the phosphate accumulation. So just because it's being administered and it primarily stays in the intestinal tract, it doesn't mean that some of those cations aren't in fact being absorbed. And we can get into trouble, as we've learned from the past. We've got polymer type laxatives. And again, in this category of hyperosmotics, these just have a large molecular weight that causes that osmotic effect, that draws fluid into the colon and increases the intraluminal pressure. Again, they create an osmotic effect. Glycerin also falls into the polymer category. Glycerin serves as an irritant. So if people use glycerin suppositories, they go right into the rectum. And again, topically, they serve to mechanistically stimulate the rectum, cause a little bit of distension, maybe a little bit of lubrication, but also that irritant effect can be enough to stimulate a bowel movement some. Again, the difference between products in the polymer type category is how fast they work. Polyethylene glycol, or something that's taken by mouth, sort of dose dependent. It may take a couple of days, or if the individual is told by their gastroenterologist, we'll take that whole 238 gram bottle as a bowel prep, it may just take several hours in order to see the effect from that. Glycerin suppositories may work almost instantly, like within 10 or 15 minutes. And then we've got stimulants. Stimulants stimulate peristalsis because they are irritating to the gastric mucosa, or to the local mucosa in the colon. They also work to stimulate fluid and electrolyte secretion. Usually we use them as part of a bowel prep procedure, but again, if somebody is acutely constipated and they are looking for some type of fairly rapid relief, the stimulants can be indicated. We also use the stimulants in conjunction with stool softeners to prevent opioid-induced constipation, right? You've got to have the mush and the push. So these are the push, and the mush comes from our stool softeners. Again, many of these drugs cause cramping, electrolyte imbalances, and malabsorption. These drugs usually have an onset between 6 and 12 hours. So with Senecot, Sena falls into this category. We give it to patients at bedtime in hopes that they wake up in the morning 6 to 8 hours later and then have their bowel movement. So again, it takes a little bit of time for these guys to exert their effect. The deal with Sena, chronic use can discolor the intestines. It's usually described by the gastroenterologist or the colorectal surgeon when they go in and do a procedure. It can also discolor the urine. Sena is really a dye. So again, it's always a good idea to give a heads up that somebody might experience pink urine so they realize they're not bleeding. Bisacodyl. Again, bisacodyl is sometimes marketed for acute constipation relief. Chronically, it can cause different metabolic abnormalities, hypocalcemia, and malabsorption. Again, glycerin suppositories and even castor oil falls under this category. And then finally, we have emollients, or stool softeners. These are essentially surfactants that work to break up the surface tension of the stool in the colon. They soften feces by increasing the wetting efficiency of water in the intestines. They're not absorbed, so they stay in the gastrointestinal tract. Very well tolerated, although some mild abdominal cramping may be reported with use. And interestingly, our stool softeners can actually interact with and increase the absorption of drugs like digoxin, warfarin, or even mineral oil. Again, docusate is sort of the brand name here, docusate sodium or docusate calcium. They both work similarly with regards to their surfactant effects. Also, some people will use mineral oil, and mineral oil also softens feces by coating the stool and then preventing water loss. Usually it's indicated for short-term use when patients are not, it's undesirable for patients to strain. So post-cardiac surgery, post-abdominal surgery, very often patients will be prescribed a cocktail of, or told to pick up at the pharmacy, some type of stool softener. Mineral oil could be used, although I think docusate is probably more common. People have developed aspiration. So important if mineral oil is being used to remind about how to consume it safely and to avoid this risk of aspiration, which could have some serious ramifications. Remember, our older adults are sensitive to shifts in fluid and electrolytes. We really need to use caution in this population when recommending use of saline laxatives or those hyperosmotics that we mentioned. Tap water enemas or saline enemas for acute constipation can be utilized. Again, many of these enema preparations, they sort of have a twofold effect. You're delivering the hyperosmotic right to the colon, right to the rectum. It's serving as a mechanical stimulus, causing distension of the rectum that may mechanically cause evacuation of stool contents. And then also in the case of tap water or soap suds enemas, it may sort of break up any surface tension or impaction that could be present. Remember, for most individuals, bulk-forming agents are preferred. And then for pregnant individuals who've got constipation related to pregnancy, it's dietary modification that's recommended as a first line. We need to think about some of the adverse effects. And then, of course, have that woman's buy-in from her OBGYN. Usually products like docusate are safe to use in pregnancy, but we always want to make sure that the physician's got the input in this decision. For constipation, remember, you have to identify the cause. What's causing it is sort of the best way to take an approach to determine what's going to be the most effective at alleviating it. And keeping in mind that most people will benefit from diet and lifestyle interventions. Our over-the-counter use of laxatives are limited to use less than 1 week. So if an individual is requiring use of laxatives beyond a week, it's medical evaluation. That's what you're going to find labeled on the products, and that's what you're going to find indicated when you sort of look at these products and in making these recommendations. All right, I'll conclude just talking a little bit about diarrhea. I'll do my best to get through this in just the 4 short minutes that we have left. Diarrhea, of course, is an abnormal increase in stool frequency or liquidity compared to a patient's normal bowel movements. Acute diarrhea is usually self-limiting, and it resolves on its own if you've made no intervention. In many instances, diarrhea would resolve, or certainly in under 2 weeks, it will resolve in most instances without any intervention. Causes of diarrhea, multifactorial. As humans, we're always eating, so we oftentimes attribute diarrhea to something we ate or food poisoning. We've got, of course, infectious agents that can cause diarrhea, and it's either the agent themselves or some of their toxins that they produce. Food poisonings, food intolerances, like lactose intolerance, as we had mentioned. And, of course, a multitude of medications. 25% of drug-induced causes of diarrhea can be attributed to which class of drugs? Any guesses? Antibiotics. Absolutely, hands down, antibiotics are a notorious offender here. Metoclopramide, I see this all the time in the inpatient setting. Oh, our patient's got diarrhea. Let's go send them for a stool specimen and evaluate for C. diff. You have them on Reglan. If you're speeding things up in the upper GI tract, of course, that's going to sort of stimulate peristalsis and what's happening throughout the rest of the gastrointestinal tract. So important to recognize these potential drug-related causes. Ideally, we see a lot of overlap with diarrhea as we see with vomiting. Prevent and correct fluid and electrolyte losses, relieve the individual symptoms if we can, identify, correct the underlying cause, and prevent morbidity and mortality, because globally, throughout the world, acute diarrheal illnesses are attributed to significant morbidity and mortality. Symptomatic relief. We've got loperamide, which is really the agent of choice, our non-prescriptive antidiarrheal agent. It's really indicated for mild to moderate, uncomplicated acute diarrhea. And then, of course, we've got oral rehydration solutions, and we also have good old Pepto-Bismol. So bismuth, again, comes into play here as a potential option. Bismuth is also sometimes indicated for traveler's diarrhea. You can bring bismuth with you if you're going to be traveling, or use it because it's got that little mild antibacterial effect, so that could be an option. Blood is an exclusion, severe abdominal pain, little tiny itty bitty kids who could become dehydrated. Only patients who've got acute, mild to moderate diarrhea with a recent onset, symptoms that have happened in the last 48 hours or less, are eligible for self-care, is what I'd like you to remember. Non-drugs, oral rehydration, like we mentioned. Dietary management, again, I think this is a common sense approach. They used to say we should recommend the BRAT diet. BRAT is an acronym that stands for bananas and rice, applesauce and toast. Nowadays they say, well, if you adhere to the BRAT diet, you're not going to meet your normal daily nutritional requirements. Well, yes, that's true. We shouldn't encourage people to do this for prolonged periods of time, but for 12 to 24 hours, while you're experiencing acute self-limiting diarrhea, it may be appropriate to sort of back off on the dietary fats and consume sort of these bland foods to help the GI tract recover. Of course, if it's infectious, we want you to sort of stay away, wash your hands, use caution when traveling to high-risk areas or when handling food products. All right, so on Wednesday, we'll pick up in our section and we'll just wrap up talking about our different drug therapies. I'm going to give you some patient case scenarios to work on, so that'll be the plan. Have a good one. I'll see you guys then.
I could tack on maybe 2 or 3 for unknowns.
John, what's your pocket?
It's going to be a bad stomach.
Oh, yeah.